Schistosomiasis is my today's topic for discussion. The term schistosomiasis or Bilharzia encompasses the acute and the chronic inflammatory disorders caused by human infection with Schistosoma species. Disease is related to both the systemic and the focal effect of Schistosoma infection and also host immune response triggered by the parasite X deposited in the tissue. So the disease caused by Schistosoma is either due to systemic and the focal effect of Schistosoma infection or host immune response to the eggs. Schistosoma organisms are trematodes or blood flukes because they parasite the blood stream. 5 Schistosoma species infect humans. Those include Schistosoma hematobium, mansoni, japonicum, intercalatum, and mekongi. Humans are infected through contact with water contaminated with Cercaria, the free-living infective stage of the parasite. This motile forked tail organism emerge from infected snails and are capable of penetrating intact human skin. As they reach maturity, adult worms migrate to specific anatomic sites, which is a characteristic of each Schistosoma species. Schistosoma hematobium migrate to the perivesical and periuretral venous plexus, mansoni to inferior mesenteric veins, japonicum to superior mesenteric veins, intercalatum and mekongi are usually found in the mesenteric vessels. Adult Schistosoma worms, which are 1 to 2 cm long, are clearly adapted for an intravascular existence. The female accompanies the male in a groove formed by the lateral edge of its body. Parasite eggs provoke a significant granulomatous inflammatory response that allows them to ulcerate through host tissue to reach the lumen of the urinary tract or the intestine. They are carried to the outside environment in urine or feces, depending on the species, where they will hatch if deposited in fresh water. Motile Mercedia emerge, infect specific freshwater snail intermediate host, and divide asexually. After 1 to 3 months, the infective Cercaria are released from the snail into the contaminated water. Regarding epidemiology, Schistosomiasis infects more than 300 million people worldwide, primarily children and young adults. There are 3.3 million disabled adjusted life years attributed to Schistosomiasis. This makes it the second most disabling parasite after malaria. Humans are the main definitive hosts for the 5 clinically important species of Schistosoma. So transmission depends on water contaminated by human excreta, the presence of specific intermediate snail host, and the pattern of water contact and the social habit of the population. Both early and the late manifestation of schistosomiasis are immunologically mediated. Acute schistosomiasis or early form known as Katayama syndrome is a febrile illness that represents an immune complex disease associated with early infection and oviposition. The major pathology infection occurs later, or in the case of chronic schistosomiasis. In this case, there is a retention of eggs in the host tissue, which is associated with chronic granulomatous injury. Eggs may be trapped at sites of deposition, such as urinary bladder, ureters, and intestine, or may be carried by the bloodstream to other organs, most frequently the liver and less often the lungs and the CNS. When we came to clinical manifestations, 2 main chronic clinical syndromes arise from Schistosoma species. The first is urogenital schistosomiasis, which is caused by Schistosoma hematobium, and intestinal schistosomiasis, caused by Schistosoma mansoni and japonicum. So urogenital is mainly hematobium, intestinal is mainly mansoni and japonicum. Most chronically infected individuals experience mild symptoms and may not seek medical attention. The more severe symptoms of schistosomiasis occur mainly in those who are heavily infected or who have been infected over long periods. In addition to organ-specific morbidities, infected patients frequently demonstrate anemia, chronic pain, diarrhea, exercise intolerance, chronic undernutrition, which causes growth stunting. So we classify the clinical symptoms into three. The first is during cercardial penetration to the skin. The second is acute. The third is chronic. Cercardial penetration of human skin might result in papular pruritic rash known as schistosomal dermatitis or swimmer's itch, whereas acute schistosomiasis or Katayama syndrome may occur, particularly in heavily infected individuals, 1 to 2 months after exposure. This is an acute febrile illness characterized by acute onset of fever, cough, chills, sweating, abdominal pain, hepatosplenomegaly, lymphadenopathy, and the like. The third is the chronic one. Chronic one is classified as symptomatic and asymptomatic. Asymptomatic children with chronic urogenital schistosomiasis usually complain of frequency, dysuria, and hematuria. The advanced stages of urogenital schistosomiasis are associated with chronic renal failure, secondary infection, and squamous carcinoma of the bladder. So this is mainly due to schistosoma hematobium. An important complication of schistosoma hematobium infection is female genital schistosomiasis. Eggs migrate from the vesical plexus to lodge in the female genital tract, where they induce a granulomatous inflammatory response. This can manifest as contact bleeding, pain, and eventual infertility. Male genital schistosomiasis can also present with hematospermia, pain, and lumpy semen. Children with chronic schistosomiasis, the intestinal type, which is caused by Mansoni japonicum or intercalatum, can present with colic abdominal pain, biliary diarrhea, and the like. Colic abdominal pain and biliary diarrhea are the most common symptoms. However, intestinal phase may remain subclinical, and the late syndrome of hepatosplenomegaly, portal hypertension, ascites, hematemesis might be the final clinical presentation. Liver disease is caused by granuloma formation and the subsequent periportal fibrosis. No appreciable liver cell injury occurs. So most of the time, liver parenchyma is normal. It is periportal fibrosis due to granuloma formation, and hepatic function may be preserved for a long time. Schistosoma X may escape into the lungs, causing pulmonary hypertension and the cor pulmonale. Schistosoma japonicum worms may migrate to the brain vasculature and produce localized lesions that cause seizure. Regarding diagnosis, schistosoma eggs are found in the excreta of infected individuals. Quantitative methods should be used to provide an indication of the burden of infection. For diagnosis of schistosoma hematobium infection, a volume of 10 ml of urine should be collected around midday, because midday is the time of maximal egg excretion, and filtered for microscopic examination. Stool examination by the catocasistic smear and detection of parasite antigen in patient serum or urine are the method of choice for diagnosis and the quantification of other schistosoma infection, such as Mansoni and japonicum. This is eggs from the three species of schistosoma. The left one is Schistosoma mansoni, and the right one is Schistosoma japonicum. The middle one is Schistosoma hematobium. The recommended treatment for all schistosomiasis is praziquantel, 40 mg per kg per day in 3 divided doses for 1 day. In the case of Schistosoma hematobium, Mansoni and intercalatum, and 60 mg per kg per day in 3 divided doses for Schistosoma japonicum and Makongi. A second treatment 4 to 6 weeks after the first course, months after the first course, may help in eliminating residual infection. The final one is about the issue of prevention. Schistosomiasis control focuses on reducing disease through periodic, large-scale population treatment with praziquantel, and a more comprehensive approach including for clear water, adequate sanitation, snail control, Those things, they help to reduce the transmission. Ultimately, control of schistosomiasis is closely linked to economic and social development. This is all about schistosomiasis. Thank you for subscribing and watching.